Okay, can everybody hear me? Does it sound good back there? Okay, great. Hi, everybody. Thank you for being here. Welcome to our breakout session. We are the Substance Use Disorder Work Group from the Texas Coalition for Healthy Minds. I'm Sydney Carter. I'm the Substance Use Work Group co-chair, and I also work at the Network of Behavioral Health Providers in Houston. Their policy program and special projects manager. So it's nice to see you all. Thank you for being here. I do want to take a moment to let our work group members introduce themselves. So I don't know if you want to start, Elizabeth. Sorry, we have to pass the mic. So.
Hi, you guys. I'm Elizabeth Henry. I'm the Director of Policy with Recovery People and a woman in long-term recovery.
Yay. Great, and I'll just pass it to this table.
Hi, I'm Sherry Layton. I'm with La Hacienda Treatment Center on the Substance Use Work Group. I represent the Texas Association of Addiction Professionals.
Good morning, Leah Davies from the Clean Cause Foundation.
Good morning, Julie McElrath. I am president of the Clean Cause Foundation and a very grateful SUD board member. Committee member.
Yeah, same. Yes. Okay, great. Yes. And so we have other members of our work group as well that you'll probably see floating around today, or if they come in, but this is kind of who's in here for now. Okay, so I think we can go on. So I kind of did that. Okay, so now, so now we're actually going to go right into an activity. So it's going to be at your tables, and I'll pass it to my colleagues here and let them kind of guide you through.
All right, so first what we're going to do is individually by yourself, we are going to spend about a minute, maybe 2 minutes, and on your index cards, if you will write down what you think 3 to 5 substance use related policy issues or problems for Texas might be. It's only your opinion. We really just want to know what y'all's opinion are on this subject. So spend about 1 minute, maybe 2 at the most, and just jot down maybe 3 to 5 substance use related issues that you see in Texas. All right, how's everybody doing on their ideas? Okay. So next we're going to have you pair up, but as I'm sitting here looking at this, so now what I want you to do, we're going to skip the pair part. As a table, I want you guys we'll spend about 5 minutes doing this. I want you guys to share what your ideas were around what substance use policy issues there are in Texas. And then as a group, we'll do that for about 5 minutes. And as a group, we'll have you guys report out. And I think we might be interested to see what some of our overlaps might be. And we're always looking for new ideas. And one of the things that we're using this exercise for is for you guys to give us new perspectives and new ideas, right? Because we get pretty involved and entrenched in what our priorities are. So it's great to hear from the community and people in other parts of our world, if you will, what they're seeing and what they see as a priority. All right, so let's take about 5 minutes, discuss as a group, make sure to have some candy, it's important. And then we'll get together as a full group.
Okay. I think we are just about done.
This is great conversation.
Yes. No, so now that y'all have had a chance to share at your table, we're gonna ask one table representative to share from your group, and we're gonna break down kind of the main ideas, and have a discussion from there. So does any table want to start first?
Your first victim.
I'll go. Volunteer.
Cool.
Excellent. I think it was a consensus at our table.
Real quick, could you introduce yourselves before you so we know who's in the room? That'd be great.
Hi, I'm Carrie Stitt. I'm president and CEO of Youth 180. We're located in Dallas, and we're one of the only outpatient treatment centers for youth in Dallas.
Hi, I'm Valerie, and I'm with Rise Recovery in San Antonio, where we provide different types of services for not only youth, but we have the first recovery high school in San Antonio. We also have the family program that works on families who are going wide range of stuff. And then, yeah, we also have a youth program. So let's see if I can make this more.
Big fan of
Oh, I mean,
Rise.
we're sitting right here.
Big fan of Rise Recovery here. I'll connect with you later.
Oh. Wow. Okay, I feel like I have to go like this. I don't know why. My name is Denise Franklin. So I had a name change, so I'm a Justin. I am the Director of Development and Generosity for NAMI Central Texas. For those of you who don't know, National Alliance on Mental Health. And we provide education and support services for those struggling with mental health. In 6 counties, so Central Texas, yes.
Okay, so it was kind of a consensus for us. So the first thing we said was access to treatment. But then as we dug a little deeper, access to treatment is driven by low reimbursement rates for, yeah. Oh, wow, I didn't realize we were gonna have a party. Yeah, so that was our first one. Do I just talk about one or is? Oh, all of them. Okay. Well, okay. Well, I'm gonna pass it. I have one more, but then I'll pass it to you guys.
You named mine.
Oh.
My big one was access to care.
Yes, access to care, low reimbursement rates, and then I'm coming from a youth perspective. We try to provide integrated care as much as possible, so our clinicians are duly diagnosed or duly licensed. God, I hope. Some of them may be duly diagnosed too. Yes, there you go. But Medicaid does not fund integrated care, meaning if we are to provide a substance use treatment in one day, we cannot also provide a mental health treatment in the same day and be able to bill for that. So just kind of, and I guess it's really about providing evidence-based practices, right? I mean, we know that a lot of substance use is co-occurring with mental health. And so what are the best practices and why is Texas so behind on that? I'm sure we could spend a whole day on that, but yeah, and at that time I'll pass. Whoever, do y'all have one more? Do you have any? No. Yeah, go ahead.
I just said the quality of care. I work at Rise Recovery as a peer coach, and I'm both certified in recovery support specialist, but also mental health support. And what we've noticed is that when we send people out or have to refer them, is that sometimes they come back with like just not the best opinion on what was going on. We find that when they come back to us, like they're extremely happy to come back because we come from a peer approach, not so much of like this is what you do. And so I used to work at the Recovery High School, so I worked really close with the youth. And yeah, they would tell me all about the quality of care and just how like sometimes it felt like they weren't seen, they weren't heard, they were being told what to do rather than, you know, people trying to understand or support them through their struggles. And so, yeah, I think the quality of that is what needs to change as well, because if they don't feel like opening up and they don't feel like, you know, they can trust the people they're working with, if you've ever worked with a teen, then you know that that's where they stop. They just shut down. And so, yeah, the quality of what's going on rather than, you know, the being told what to do. Somebody else can take this.
Please let us know who you are and then what are your top 3?
Hi, I'm Anushka Gupta. I'm currently a Youth Spark Change peer facilitator for the Girls Empowerment Network.
I'm Ira Salam. I'm also a past the 2024 cohort for the Girls Empowerment Network.
So we're not as experienced in terms of specific policy issues, but with our experience in school, we talked about education programs. At least for me at my high school in Round Rock ISD, there's the DARE program, which was briefly introduced to us to kind of, I'm not even sure, but it was introduced to us and it was very brief and we kind of thought it was ineffective. So I guess that goes back to the quality of care, because the people who do end up teaching the program, okay, the people who do end up teaching the program and the type of information they introduce isn't necessarily effective in the long term and isn't reintroduced to students. So we thought that that was a big issue.
Do you have any more?
Just generally a lack of support resources for students. A lot of times students at, I think both, she goes to Westlake, I go to Westwood High School, kind of fear seeking out counselors at the school themselves because oftentimes there might be repercussions for seeking these people out, whether that be academic-wise or that be, you know, some extent of privacy is really, I mean, obviously there's specific burdens that, you know, teachers, staff, schools have to uphold, but at some point of time, youth kind of just need a safe space in order to confide in someone. And if there's a threat of someone who may be, you know, inducing mental health issues or just someone who you might not have turned to in the first place to confide in because of your mental health issues, it becomes immediately more difficult and you become more reluctant to seek out those resources in the first place. So.
This one's working now.
Okay.
Julie, you might put up their prevention programming too.
I'll start first. You just introduce yourself. Hi, I'm Mackenzie. I am a HOG mental health policy fellow with Texas Association of Community Health Centers. So we represent all of the, oh yeah, you guys like us. So we represent all of the, or you like the hog fellow, I'm not sure. But anyways, we represent all of the community health centers or federally qualified health centers across Texas. There is 73 and 650 clinics. And we provide integrative care, primary care, and behavioral health and substance use services. And I'm doing a project right now on peer support, so I'm very interested in that and something that we've talked about. One of the policies was first off, providing youth and certified family to be reimbursed and certified, reimbursed through Medicaid. And HHS is working right now on that, so hopefully they'll get faster on the process. And also so right now Medicaid policy says it's only reimbursed for recipients 21 and older. So we are advocating for 16 and older because a lot of the patients we serve on Medicaid are adolescents. And I will let everyone else introduce themselves and say one.
My name is Hannah Frankel. I'm a clinical social worker in private practice. I'm not affiliated with another organization professionally. I work for myself, so I'm not really in the policy world very much, but I've always been curious about it. I do work with people 13 and up, and I have kind of a concentration of teenagers, later teens, emerging adults, folks in their 20s, and people at various stages in their recovery journey that are seeking mental health services, but recovery and addiction and substance abuse are part of that picture too. Yeah, it's fun to be here in the room with all you smarty pants policy people. Am I supposed to say one of these? We said money for everything. I think I'll let you speak to that in more detail, but sure. So funding for services at all levels of care so that people can access care when they want it and when they're ready. That's been a barrier for a number of my clients that, hey, I'd love to go to recovery, or I'd love to go I'd love to go to detox. I'd love to go to rehab. I'd love to start that, but logistically, I don't know how that's going to work. I don't know how I can take time off from work. I don't know how I can get childcare. I don't know how I can pay for it. So there's so many financial barriers. We talked a little bit about OSAR. I feel like my info's a little out of date on this because I worked at Detox and Inpatient about between 8 and 10 years ago in that time frame, and OSAR was just a beast to work with. Okay, yeah, the money ran out real fast, and it really was kind of one of those it felt like a mock-up program, and I'm happy to hear updated information, but there's a program, but it doesn't actually work. It's like, yay, we can wave a flag, but nobody can actually seem to get help through it. And I'll let somebody else kind of clean up some of that more clinical perspective.
Hi, I'm Jessie Higgins. I'm the Chief Mental Health Officer for the City of San Antonio. And so actually, we kind of hacked this last week. I worked with STRAC and with the leadership at Rise Recovery last week on our substance use policy agenda. So I had a long list. But yeah, so in addition to the things that have already been mentioned, the reimbursement rate for treatment centers that allow women, residential treatment centers that allow women to stay there with their children is really cost prohibitive to actually have that happen. And so what you have is a lot of women who just won't seek treatment because they're afraid of losing their kids in the CPS system, or they just don't have childcare. We are definitely pro-drug checking mechanisms. I heard new vocabulary to learn today. Expanding harm reduction, substance use services in alternative schools. I get that it's hard to get them in regular high schools, but the fact that after the vaping laws changed last year and we're sending a bunch of kids who were quite frankly addicted hopefully only to nicotine, but they're addicted to a substance and they're being sent to alternative school as a practice, then we should have substance use treatment in schools and alternative schools. If we could bill for youth peers, we could have that funded as well. And then do you want to talk about meth? Are you going to talk about it, John? All right, so I'm going to talk about it. So in Bexar County, more people died of an overdose related to meth than opioids in the last 2 years. And we know that that's because of Narcan. There's an anecdote. We don't want to pull back on any of those interventions, but there's not enough evidence-based practices and research done in methamphetamine treatment. And quite frankly, in Texas, we're kind of ugly about it. And so that's, I don't know, we'll change the ugliness. You can do that, right? And then, we can do it, okay. And then the last thing on my list was for adult peer services, we'd love to change the background, the criminal background. Some of the requirements are 5 years. If we could change it to 3 years, just giving people more of an entry ramp into that profession. Again, I came prepared, so.
Hello, y'all. I'm Cole Gloucester, and I am, along with Mackenzie, a HOG Mental Health Policy Fellow, and I'm a fellow with the Coalition of Texans with Disabilities. Substance use disorders are something that I'm kind of trying to be familiar with, but I think for me, I'm assuming an educated guess here, but I'm assuming affordable housing solutions like near treatment facilities and that are close by is definitely probably a big issue that is facing the state. So.
Well, we're glad to have a Smarty Pants clinical person who is excited to learn about policy. So welcome and thank you.
Hi, I'm Rachel Quevedo. I'm with Representative Christian Manuel's office. Let me see. One of the things that we discussed was also youth education and prevention. I remember DARE in school, and I found it very ineffective. And I just think I was also a high school teacher for a couple of years, and we used to have this like social emotional learning type of thing that was really good, but it was kind of like an optional thing. So it had great content, but if we can make sure like some type of program where all kids have access to it, not just specifically, certain kids who were, chosen for those things. I think that was one of them. So yeah, youth education prevention in schools.
Hello, my name is John, and if you have 30 to 45 minutes, I can really explain what it is I actually do for a living. But I'm the Assistant Director of the Southwest Texas Crisis Collaborative, which is part of the Regional Advisory Council down in Bexar County, San Antonio area. And we deal with a myriad of different programs. We facilitate programming. Some of that programming involves multidisciplinary response teams for Bexar County and the city of San Antonio. And we've also kind of gone into pre-crisis, which I think is awesome. I get the privilege to work with Miss Jessie over there from the city, and we just had a meeting, so we came prepared. It's very helpful. Sorry, I didn't think you had anything. I got a couple things. I appreciate it though. Thanks for going first. But one of the things that we talked about, so we did talk about housing, but specifically one of the things that's been brought up in some of our committees and Tiger teams is non-conditional housing. Yeah. So, you know, a person cannot recover if they don't have somewhere to sleep, and if they don't have food, and if they don't have basics. So non-conditional housing is a really important thing.
All right. Hi, I'm Jen Mudge. I'm a public policy manager with the Texas Council on Family Violence. We're the statewide coalition against domestic violence. One of the things we also talked about were having substance use prevention and treatment services that really integrate trauma and the impact of trauma. It's something we think a lot about when, you know, our focus is survivors of domestic violence and who clearly have, you know, many have experienced, you know, varying levels of trauma. So really thinking about that intersection of trauma, people who've experienced violence, and how that can be addressed in substance use prevention and treatment.
Good morning. I'm Navia with Senator Johnson's office. They kind of touched on everything we talked about, but one thing that our office has been looking at has been how Texas has been wanting to kind of mirror the Healthy Indiana Plan, which is a Medicaid program for lower income families. But it kind of has the essence of Obamacare with a more conservative kind of twist to it, where you're basically held accountable for your health care, and say you're smoking or you're doing some type of drug, you face penalties on your health care and what access you're provided. But one thing I think it's an issue with that is when you face these penalties, they're not really giving you any resources to not do drugs, or they're not giving you any rehabilitation resources that would help you prevent being in an environment to face those penalties. So I think it kind of works backwards a little bit.
Oh, sorry, we're all taking it wrong. Nadia's like, no. Everyone use that other one anyway. Or does that,
All right.
I don't know. That one works.
Thank you, guys. We really appreciate, this is a great list. This is just an amazing list. You know, we did hear a little bit about it. One thing that I would like to challenge you guys to think about is to go a step past treatment and then think recovery, right? Like, so we have prevention, early intervention, harm reduction, treatment, recovery. So I think one of the things that I see, one of the things that I see, and it's not just Texas, but this is where we work, right? One of the things that I see happening in Texas is the recovery support service is often an afterthought if it's a thought, right? So we have these very important parts of our continuum, and one of the things that helps treatment to be so incredibly effective is the support that comes when people are reintegrated back into our community, right? So that would be my only challenge for you guys. And I heard some amazing things, I'm gonna be partial as a person in recovery, about peer support, which is huge, and definitely an emerging workforce that we have in Texas. So I will be contacting all of you guys that talked about peer support, just to let you know. You get some random email from somebody, that's me. Anything else till we go to the next one?
I think real quick, I was thinking where you were. I mean, this feels, as I think about a continuum, even though it's a non-linear continuum, I believe. Treatment is that acute care place, right, where it really gives the foundation. Most of the time, as it for what is considered to be, I believe, that chronic condition, right? I think I'm probably loud enough.
Oops, sorry. With the ongoing need for support and wellness, right, for support of an individual's wellness, funding mechanisms that support the lifespan of an individual, that's where most of the time is spent, right? So if we're not looking to support funding for the lifespan of an individual, I think we're selling ourselves short when we think about only living in that acute care model.
Yep.
I know that this isn't necessarily SUD specific related, but behavioral health workforce development issues. Because I don't think any of the stuff that's on the wall can be achieved without workforce development. I mean, we want to have access to care, but if we don't have the clinicians or people who are trained in SUD disorders or mental health disorders, then having the walls and building don't really mean anything. So one of the things that we're also starting to see is more and more young people who are Spanish speaking only. And so having a concerted effort to bring bilingual individuals into the behavioral health work field is critical to being able to address some of these things that are on the wall.
I do want to point out real quick on that note, workforce is something that Sherry has been working on, just making being an LCDC a little easier for folks, and revising some of their education requirements, continuing education requirements and hours and stuff like that. So, I mean, that is definitely something that she is our expert on over there. And also parity, that's another thing that Sherry's been working on. So it will help our clinicians if we had insurance parity, right? So it's Medicaid is great, and we definitely need more of it. Being Texas, strength-based. Being Texas, expanding Medicaid is not, it's just not something that's going to happen anytime soon. But again, still that parity issue is continuously coming up, and I know it's something that Sherry's worked on for several sessions now. So we're hoping to see more of that. And my computer just went to sleep. So. Oh no, that went out. So our slides just went down. I don't know why. Oh.
Because it's Thursday.
Yeah, I'm going with that.
Is there anything reason or are they always good?
That doesn't.
Yeah, you just turned this back on. Well, it was display computer and now it's display HDMI. Yes.
There it is. Okay.
Should we do this or go back?
Oh, we do this. So we've hit on this, you hit on this with affordable housing or non-conditional housing. I love that. I do too. 'Cause we start saying housing first at the Capitol and people get upset, but non-conditional housing is beautiful. I'm stealing that. I just want you to know that. It's awesome. It takes a village, right? All right, so what we'd like for you guys to, you want to just do this as a group? As a group is to think about where does substance use interact with mental health, the economy, child welfare, trafficking, homelessness, and other areas.
I would actually just like to say, yeah, that's right, let's go. I would actually, for the group to consider adding geography. So one of the things that we've run into, at least in the San Antonio, Bexar County area, is when we talk about transportation. So, you know, I was in the Navy and stationed in Seattle for a long time. Tons of transit options. In San Antonio, based on where you live and the economy of the area where you live, you might have a bus, but if you don't have a car, you're not getting anywhere. Yep. You're walking. Right. So that can create a significant barrier to treatment.
All right, anybody else?
In some of our safety net services is just the difficulty. They're so limited that we actually fund, according to the HHS 11 regions. So there are massive amounts of geography, and there may be 6 detox beds for a region. So the transportation actually is a huge issue. We can't get people there, and even in a city. You can be in a city and you still can't get to a program, which is why outpatient is terrific, because it's less intrusive basically to people living their lives. But that's why the residential component and being able to have residential services within our continuum is important. And so I just wanted to comment that on the geography actually impacts the ability to fill beds even, because people can't get there.
So can we do like two more ideas, and then we'll move on to our next part?
Is this working? Okay, yeah. I think as someone with personal experience in terms of the child welfare aspect of it, I think it's really difficult to try and show up for family members who are experiencing it, but that's something that's so critical when it comes to not just treatment, but recovery, which is something that we were talking about recurringly. So I think it's so important for people to have access to those resources, because I know that if they were more highly available or widely accessible, a lot of issues when it comes to child welfare wouldn't occur in the first place. And the role that, not just a child, but the rest of a family needs to play towards someone who might be going through a disorder, they can actually take up that role and take it in power and really empower and support the person who needs it most without there being harm on any side of the relationship. So.
One more? No? Okay.
Because I'm in San Antonio and we're generally a better or well-resourced city, sometimes we've got people who are in homelessness or in that would be the most marginalized, that have the most access to services, because we've built out that continuum of care at the end of the crisis line. And so I would love to see more prevention so that people are able to get the help they need before it becomes, that they've lost their job, that they've lost their housing, that they've lost their relationships, that they've lost their kids. And so it does become an economic issue, because when people are struggling in this way, hitting rock bottom is like a concept that I'm fairly familiar with, and believe that recovery is possible, and believe that when you hit rock bottom, you can, we can definitely pull you back up, and there's tons of support. But how can we help people where they're not hitting rock bottom to get the support they need? And so that's a struggle. There's such a gap in that. I feel like there's very little plateaus or tiers or terraces along. It's like a cliff, and once you hit rock bottom, then we can help you. And so that's hard for me.
The chronic nature, yeah.
Y'all are very insightful. Okay, next slide. So now we had a little teaser in our panel this morning about what our policy priorities were for our substance use work group. And so here we are. Can you go to the next slide? All right, I'm going to talk a little bit about recovery housing, and that is a huge priority issue area for me personally and for my organization, and I'm super excited that the coalition has picked it up as well. Last session, thanks to Senator Johnson, Representative Murr, and Representative Wilson, House Bill 299 passed, which created a voluntary recovery housing accreditation program in Texas. I say voluntary because we are also trying to prevent overregulation and NIMBYism at the same time. And what this did is it defined recovery housing in statute. It created a voluntary accreditation program that is in alignment with national best practice standards, and that is with the National Alliance of Recovery Residences. It also established a responsible party for NAR accredited homes and requires Health and Human Services to submit a report every December 1st of even-numbered years, so the December before legislative session starts, on the status of accredited recovery housing in Texas. So how many counties are in Texas? 254. 254. 200, hey, go Leah. She gets a sticker. 218 of those counties do not have any identified recovery housing. So it's not that they don't have accredited recovery homes, they do not have any recovery housing at all. We are also ranked 33rd in the country per capita of available recovery housing. There's only 50, so we're kind of at the bottom of that list. But what we do know is that recovery housing has shown higher employment rates, higher income levels, people are finishing their education. There is something amazing that happens when people in recovery live together, the way that they can navigate resources, the way that they can find transportation when there's not any, is just quite amazing what happens in those environments. It also reduces recidivism and improved mental health, right? Like, I mean, there's all the things that go along with our drivers of health. Next slide, please. So, of course, what we would like to do, we need money. So now we have this accredited recovery housing program that's been passed. The funding did not get passed with it. I know you guys are super surprised by that. But thankfully, again, your boss, Senator Johnson is filing a rider to fund this program. So historically, for the last 12-ish years, Texas has funded, I'm going to try to be quick, Texas has funded level 1 recovery housing. There are 4 levels, and that is Oxford House. Have any of you guys heard of Oxford House? So that is a different model of housing, and it's very much needed. But what that has done is created a huge gap in level 2 and 3 recovery housing. And so we're hoping to increase funding. We don't want to take from funding that's already in substance use and mental health because we all know there's not enough. But what we want to do is increase funding through general revenue, not be block grant dependent, not be federal dollar dependent, but through general revenue for $4.3 million over the biennium, right? So that really is microdust compared to the rest of the state's budget. And that would be specifically for the National Alliance of Recovery Residents state affiliate to accredit recovery homes and help them grow and expand. And that comes rental assistance. We don't call them housing vouchers or housing stipends because that can trigger HUD language. That would eliminate a lot of people from being eligible for it just based on their justice-involved background. So that's our big pitch for recovery housing as of right now. There are some other things that we would like to see changed in the legislation, one of them being requiring Health and Human Services to be in contract within 90 days. They like to take 2+ years to be in a contract, and they report back to the legislature they didn't use the money, and then your money goes away. The other thing would be to add into the definition that recovery homes are to be treated as a single-family unit. That's another thing that we run into, especially in the city of Houston. Not to pound on the city of Houston, but it's been a problem. So that's our big thing with recovery housing, and then I think Sherry's going to do our patient brokering.
Hi, Seth. Elizabeth introduced the idea of patient brokering in the legislation that we're hoping to get passed this session. But we have had this legislation in the last 2 sessions. It's actually done very well in the House, passed the House both times, and we were so close last year. We even had it on the local and uncontested calendar in the Senate, and then they took it off. But back in the late 80s, early 90s, I realize some of y'all weren't born yet, we had in the psychiatric and substance use industry in all across Texas and a lot of areas in the United States as well, we had a lot of abuse of the commercial insurance system, but also paying for patients, heads in beds, those kinds of things. And people would literally they would bring someone to a facility for admission, and they would literally be given a large sum of money for bringing that person to treatment. And the backstory of that was there was a lot of money to be made with their insurance policy. And so they figured it was worth the investment, okay? And so it was kickbacks. But what happens in that situation is If I know that you're going to pay me $1,200 if I bring this person to you, it may or may not be the right place for that person, the best to care for them, but it's the best for me. So that begins to drive decisions that I made. So some of that was just general folks in the recovery community. Some of that was professional people that were involved in this process. It was a huge problem, and it led to passage of legislation in 1991, I believe. Senate Bill 205 and 210 back in the 73rd session. So we have this legislation that prohibits any kind of remuneration for referrals, okay? And so that is in place. But back then, it's limited to residential care facilities, and it doesn't address things like internet marketing, because guess what? There was no internet marketing at that time. So House Bill 248 was the number from last session, and it doesn't create new laws. It basically updates and strengthens existing law and protects a vulnerable population of individuals, both in mental health and substance use, who are needing services. So if you'll flip to the next slide, please. So we want to update and strengthen the current statutes and broaden some application for that. It would establish a task force that just studies the incidence of these issues. And it would require mental health and substance use facilities to clearly distinguish between marketing activities and its clinical functions. Sometimes those get kind of gray. They were really, really gray. And there was a lot, those of you, we have so many youth people in here. In the 1990s, late 80s, there was a lot of, there was a lot of abuse in the systems relative to adolescents and people putting services into schools, pretending they were offering clinical services or support services in school, when actually it was simply a mechanism to channel kids into psychiatric hospitals. So then we want to update the types of facilities to include broader levels of care. So intensive outpatient programming and partial hospitalization programming, those levels of care really weren't utilized back then. I worked for La Hacienda Treatment Center. In 1996, we acquired an IOP in Austin. It was the only IOP, intensive outpatient program in Austin. And so now there's probably 20 intensive outpatient programs in Austin, okay? So that is a much more widely used level of care that was not included in the original legislation. Update types of marketing mechanisms. We've talked about the internet. And then it actually is, as Elizabeth talked about in the panel this morning, it actually would give a reporting mechanism so that people know, where do you take this when you find violations of these practices? So I wish this wasn't happening in Texas, but it is. We've gone full circle. And this has been a problem across the country, and as they've tightened down in Arizona, in Florida, in California, a lot of those bad actors have come to Texas. And even if they weren't intentionally bad actors, they came to Texas as an expansion because substance use treatment is expanding dramatically. And so people are coming into Texas as a new market, and people don't know this 30-plus-year-old law is even on the books. And a lot of the folks who've been around for a long time don't know this 30-year. So we need to update this. We need to get this taken care of, and we've been so close. They promised me third time's a charm. I'm going to, bank on that. So, but we need your support with that.
Yeah. So, I actually have the law. So how many people are aware that we have an overdose crisis? Yeah. That we're losing people. Can you hear me? No?
Oh, you have one?
Yeah.
Okay.
Mm-hmm. That we're losing our fellow Texans at a tremendous rate. I mean, off of the Department of State Health Services website, the most recent statistics that they've got is that we've lost 5,093 people last year. Think about that, 5,093 people lost their lives due to an overdose. And we have ways to prevent it. And that is, in addition to the naloxone, which is the overdose reversal, another method of that harm reduction is to be able to test the illicit drug supply. Last year, I actually made the mistake of saying in a law, oh, we're going to get fentanyl testing strips this year. And it seemed like we would, because the governor, who had been very unsupportive of any of those things, actually stepped out and said that he support fentanyl testing strips. Unfortunately, the bill, and there were many filed, there were like 13 or 14 fentanyl testing strips bills presented, and the one that had forward movement got all the way through the House with no opposition, but then sat in the Senate Criminal Justice Committee. And the reason why it sat in the Criminal Justice Committee is it is considered paraphernalia. It was actually put in, it was a federal law that kind of prompted the language that went really in all the states, that included the language of analyzing and testing equipment, along with bongs and all the other paraphernalia that we're more familiar with. So it has been illegal and would put individual users at jeopardy if they're caught using testing strips. The idea of a testing strip is obvious, and you test your drug to see if it has fentanyl in it, because fentanyl was responsible for 43% of those 5,093 deaths. But it's not the only thing. I heard him mention about meth. More and more fentanyl is being added to methamphetamine. It's being added to all sorts of other drugs, along with new drugs. So the new, Elizabeth mentioned it earlier about xylazine, which is a veterinary drug that basically, it's kind of like a sedative, and it allows your fentanyl high to last longer, but combined with fentanyl, it becomes more deadly, and it also has its own set of problems, which includes bad wounds that can turn into necrosis and amputation. And I guess the point is that illicit drug supply, especially nowadays, is forever changing. It is not, we do this with almost everything. There's a drug that becomes popular, and we drive everything toward that drug. Well, the reality is, by the time, if we can change minds about removing fentanyl testing strips from the list of paraphernalia, we're going to have another drug that needs to be tested for. And so instead of doing what we had done in the past, which is basically having legislation that would basically exempt fentanyl testing strip as being considered as drug paraphernalia, to be able to get ahead of the various contaminants that go into the drug supply, a lot of other states and some of the harm reduction folks have been looking at the idea of just taking the whole testing and analysis and testing out of drug paraphernalia, not just one exclusion for one drug. Community surveillance is finding it's not just the individual drug users, it can be universities, it can be other people who are basically testing that illicit drug supply. And recently, and I find this interesting, and it's something that's unprecedented because it found its way in the drug supply in Los Angeles, and it found its way in the drug supply in Philadelphia. So some of the folks watching what's going on with drug supply is a chemical called BTMPS. And what that is basically is it's an additive they put in plastics. Yeah, in plastics to kind of keep it protected from UV rays. Now, they don't know what the impact on humans is with this, but it's at high doses, and they're concerned what that chemical additive can do at high levels, which is what it's been coming in at 41% of the drugs tested. So anyway, that's just a long way to say that we need in the state of Texas to enable individuals and communities to test. And so we have kind of revised the stance of, fentanyl testing strips to say, let's expand community access to drug testing and testing supplies and equipment. And because it's our belief, any of the drug testing strips is not paraphernalia, it's prevention. And so we really want to try to move that forward. I don't know if any of you read the the news recently, there has been a reduction. And, oh, I'm sorry, thank you, Elizabeth. Yeah, I can talk and talk. But there has been a reduction in overdoses due to fentanyl. And although they can't pinpoint one reason, one of they're accrediting it to is the ability to test your drug for fentanyl. So anyway, we're going to be going after that. We don't have a bill number yet. We're going to be looking for authors. We're going to be building that one out. And your support would be great because we need to get that in our list of harm reduction strategies.
So we're just a little bit over time, so we're going to let you guys go. I know there's another session that starts about 11:15, but we welcome all of you to join us on the substance use disorder work group. Even if you just want to come personally, you do not have to commit your organization to the coalition, although I wish you would. So if y'all have any questions, we will be around for the day. I can give you my card. I think some of us others have our contact information as well. So please make sure to get with us. We're happy to chat all things SUD with you guys whenever you need. Thank you.